Good afternoon or good morning. I'm Ann Greiner, President and CEO of the Primary Care Collaborative. And for those of you joining who may not know the PCC, we are a multi-stakeholder organization that brings very diverse leaders together to advocate for improvements in the nation's health by strengthening primary care. Today's webinar, Delivering Results Whole Person Care, is part of a series focused on whole person care. But before we get into webinar specifics, let me just go through a couple of housekeeping kinds of things. Like all of our other webinars, this webinar is being recorded and will be made available within 48 hours after we complete our webinar today. It is on our website, thepcc.org, and if you're curious about prior webinars, you can also view them there. We're going to be taking questions using Zoom's Q&A tool that's usually found at the bottom of the screen. Panelists will answer those questions after we have a conversation with them, the last 10 minutes of the webinar. But please, as these questions occur to you, put them into the Q&A. The chat will be disabled, but PCC staff will be putting resources into the chat, so look for those. We're very committed to delivering high quality webinars, and we really need your suggestions on topics that we should consider, and also your feedback after the webinar. So look for a link that has an evaluation and some suggestions for future webinars. This initiative of whole person care is jointly funded by the Ardmore Institute of Health and Healing Works Foundation. And it is a 3-year initiative to promote a deeper understanding and appreciation of whole health and lifestyle medicine concepts and the evidence behind them, and to assess how we, as the primary care community, can collectively move whole health approaches into mainstream practice. Part of the project establishes a work group to advise our effort, and we've convened a really remarkable set of 14 leaders representing everyone from clinicians to health plans to employers and consumers. Our first webinar was in April related to the evidence base behind whole person care. Please avail yourself of that if you missed it. This is our second webinar, and our third webinar will be in January. It will be focused on whole person care and chronic care. So stay tuned for the exact date in January, but we hope that you're enjoying this series. Now let me introduce each of the panelists. They're going to give very brief presentations, one after the other, and then we'll open it up for some conversation. And then we'll turn to all of you for your questions and observations. I'm going to first introduce Dr. Alan Roth. He's chairman of the Medicis Health Network Department of Family Medicine, Ambulatory Care, and Community Medicine at Jamaica Hospital Medical Center and Flushing Hospital Medical Center in Queens, New York. He's also chief of integrative pain and palliative care. Alan is a practicing and academic family medicine and palliative care physician and has been the recipient of many awards, including New York Magazine Best Doctor. Congratulations, Alan. And has been featured in Time Magazine as a guardian of healthcare during the COVID-19 pandemic. Welcome, Alan. We're thrilled to have you here today. Next is Mary Delaney. She's president of Vital Insight, an Alera Group company where she excels in guiding employers towards comprehensive health solutions. That is music to our ears. In that role, she prioritizes both employee well-being and cost mitigation. And employees want cost mitigation, believe me, while also having high quality care. She's got over 2 decades of experience on the provider side in the healthcare industry and brings a wealth of knowledge and a unique perspective to her role. Her expertise includes wellness solutions, on-site clinic integration, disease and utilization management, and improved management of carriers and PBMs. And last but not least is Dr. Pajma Patel. Pajmaja Patel is a board certified internist specializing in lifestyle medicine and healthcare transformation strategies. Dr. Patel holds the position of president-elect at the American College of Lifestyle Medicine and is currently the vice president of the World Lifestyle Medicine Organization. In addition, she serves as vice president of Midland Quality Alliance and the chair of Quality Committee and chair of the Quality Committee at an ACO REACH model located in Midland, Texas. She's also a consultant for the Texas Medical Board's Committee on Alternative Payment Models. Okay, so without further ado, let's hear from our panelists and then we'll have a conversation. Thank you.
So thanks, Anne, for the kind introduction. I've been at Jamaica for 38 years caring for an underserved population and learned way back that we have a dysfunctional market-driven healthcare system and was really seeing little differences in improving the healthcare of our community. Next slide. Fortunately, several years back, I was at a conference from the FMEC on Innovators Network and was fortunate enough to spend some time with both Dr. Jonas and a team from Converging Health having a discussion of what's wrong with our system. And it became clear then that the dysfunctional system needs to be organized, one that is based on a whole person advanced primary care model that's based on wellness, health, prevention, early intervention, and changing after, chronic complex diseases is not the way to go. And one of the strategies we used was to risk stratify our patients and change from a reactive way of taking care of our underserved patients to a more proactive one, bringing our patients in for what we call high-value visits, where we give our docs 45 minutes to care for the patients that they need and address all of the healthcare problems as well as the health-related social needs. Next slide. So we use data analytics to get out to our patients, brought them into a team-based approach to care, risk stratified, and then brought people back in a circle and continue to do this time and time again with each patient that we see. Next slide. So we take care of the patients all equally. It doesn't matter the insurance, but we're fortunate enough to be in a high value based and globally capitated environment. It's a little hard for me to explain this slide quickly, but the patients on the right lower quadrant of the side are high risk patients based on the risk score. And the patients on the right upper quadrant are the highest risk or unfortunately what super utilizer kinds of patients. By focusing on these patients, we were able to show, utilizing high-value visits, a significant reduction in the cost of care for our patients, but more importantly, in the quality of care and the lowering of the risk of the patients that we would be taking care of. Next slide. So by utilizing this more proactive than reactive, going from sick care to well care, focusing on care gaps, we were able to show tremendous savings in the cost of care. So in our globally capitated patient model, over the 3 years that we now have data, we were able to show a reduction in these high-risk patients and right lower quadrant, which were those that are about to become the highest risk quadrant, a $471 per month per member per year implementation reduced cost. And we're talking about a population of close to 40,000 people. We were able to show reductions in our ER visits by about 22% and a reduction in hospital days by 20%. But most importantly, we were able to really meet the quintuple aim here. Our doctors were happier, our patients were happier, we improved our quality, and we lowered our cost.
So I actually work more on the commercial health plan side of the world and deal with really just health plans paid by the employers. So in my example, in the next slide, I'm going to talk about one of the largest success stories we've seen. So this is an organization, next slide please, that it's a school system. Carmel Clay Schools is a large school system in Carmel, Indiana. They have about 3,000 members on their plan. And they started in 2012. I'll call it a near site clinic because obviously with schools, there's locations over a very large county area. They reviewed, really I give them a lot of credit because they started with a provider, nurse, and an administrator, and they really started kind of using the data and their experiences to determine what resources people needed in order to support them on their journey to improved health. The magic of this group versus so many other clinics that we work with is that their medical director was a driving force in developing an environment where they focus on investing the time and the people to help people find their why, and really gain trust in the population, allowed them to be vulnerable, and really got to understand exactly what resources were needed. I just, as I listened to your April podcast from PCC, I heard the providers talk about a shift from what matters, what is the matter with the person, to what matters to the person. And I would tell you that's exactly what this group was doing. So in that, they started to, as you can see, expand as they were able to save money. They expanded the resources that were required so that they added exercise physiologists. They added a registered dietitian, a wellness coordinator who actually does yoga classes, other support structures. I believe now they have 3 mental health therapists, a women's specialist. So all these resources were added by, as they were reducing the plan spend, they were able to reinvest those resources into a more richer environment to really help support the individuals. What is been really wonderful about this is that the associate superintendent who's in charge of this program from the employer side has always said, invest in the people first, and that, the rest of that will follow. And they've been able to do that. So what you see here is that we leverage Johns Hopkins risk indexing. So we're able to identify who the future cost drivers are in this population. So that's that 7 to 6% that will be more than 50% of plan spend next year. And in this information, you can see that they have done an incredible job actually engaging those people, and it's completely voluntary who engages in this program. And with that, we also can see down in the lower right-hand corner is that on a cost per unit risk for total healthcare spend, including the cost for this program, the people that are participating in the clinic are costing less. We're seeing a larger drop in their future risk scores. So actually their prospective risk scores are getting better at a higher rate than those non-participating, and they're engaging the highest risk people. So we're able to prove that they're actually improving health along with providing a better service. On the next slide, what's really exciting is as you look at this data, they went from 12% of their population with type 2 diabetes now to 8%. So we are seeing disease reversal or remission, and doing that while they're still improving costs. So the orange line is showing you the cost that would have equated to the PwC trend for commercial health plans, and the blue line is their actual cost. That led this program to a $6.5 million savings in 2023 over a $25 million budget. So they've been able to prove in this model of really dealing with helping the person working on what they need and how to associate with that need and how to provide the right resources, which has been incredibly empowering to the individual, that they've also been able to save money.
So thank you, Anne, for this wonderful opportunity to share some of the impactful work I've been part of and to highlight some exciting outcomes from lifestyle medicine clinicians. As a primary care physician, I embarked on my lifestyle medicine journey by serving as a medical director for the Ornish program for reversing heart disease at a local hospital, Midland Health in Midland, Texas. This program has been scientifically proven to prevent and in many cases reverse the progression of heart disease. Its holistic team-based approach addresses critical aspects of health, including nutrition, physical activity, stress management, and group support, offering patients a comprehensive pathway to better health. On average, CMS reimburses approximately $8,000 to $9,000 per patient who completes all program sessions, making it a sustainable financial model for primary care in fee-for-service models. Next slide, please. One of the most compelling pieces of evidence supporting the Ornish program comes from the Mutual of Omaha Claims Data Study published in the American Journal of Cardiology back in 1998. So this data has been around for a very long time. In this study, out of 333 patients requiring revascularization, 194 patients underwent Ornish lifestyle program, whereas 139 received standard interventions like stent placement or coronary bypass surgery. After 3 years follow-up data, results were striking. Only 57 patients in the Ornish group needed additional procedures compared to 173 procedures in the control group. And this translated to a 47% decrease in total healthcare costs for patients who underwent Ornish lifestyle program. In addition, in a separate Highmark study, Dr. Ornish demonstrated a 55% reduction in emergency room visits and an 84% reduction in inpatient admissions. Even more impressive is the long-term adherence to lifestyle changes. Dr. Ornish's research demonstrated that 90% of patients continued following the lifestyle modifications 1 year after completing the program. This sustained commitment underscores the program's ability to drive not only clinical improvements, but also meaningful behavioral change, resulting in lasting health benefits for patients. Second slide, please. At Midland Health, we designed a similar intensive lifestyle program specifically for employee health because we are a self-insured entity. After enrolling 150 employees in a 12-week intensive lifestyle change program, which offered didactic lessons, health coaching, and ongoing support focusing on the 6 pillars of lifestyle medicine, we achieved remarkable results. The program not only improved health outcomes, but also demonstrated significant cost savings. 1 year later, we saw $2 million reduction in hospitalization and saved approximately about $1 million in pharmacy spending. Beyond the financial impact, the program initiated a cultural shift within the organization. We took key steps such as making genetic prescriptions mandatory and revising our employee benefit plan to align with wellness principles. Through this comprehensive approach, we successfully demonstrated that investing in lifestyle medicine programs can yield substantial financial and health benefits while also nurturing a healthier workforce and organizational culture. Next slide, please. The third powerful example of lifestyle medicine integration comes from Dr. Wayne Dysinger's primary care practice in Southern California. Operating within a value-based Medicare Advantage payment model, Dr. Dysinger has demonstrated the success of lifestyle medicine in primary care by achieving the triple aim: improving health outcomes, reducing cost, and enhancing patient satisfaction. The clinical outcomes of this practice are notable: 20% reduction in LDL cholesterol, 12% reduction in hemoglobin A1c, and 9% reduction in BMI among patients participating in the program. Beyond these clinical improvements, he has also demonstrated 40% reduction in the total cost of care, showcasing the financial viability of integrating lifestyle medicine into a value-based care model. And equally impressive is the patient satisfaction, reflected in a Net Promoter Score of 83, indicating higher levels of patient engagement and approval. This model underscores the effectiveness of lifestyle medicine, not only in managing chronic diseases, but also in delivering cost-effective, patient-centered care that aligns with value-based care payment models. So these 3 examples really demonstrate that whole person care can be delivered in diverse settings and within different payment models. Thank you.
Work not really expanding upon the whole concept, where this really was the concept of, we're not forcing people to join. And if they're not ready to meet with the provider, then let them take advantage of the yoga classes. And then maybe through that, the exercise physiologist can convince them to go meet with a counselor, mental health counselor. And as they heal in certain areas, then they're ready to really talk to the provider about how do they manage their hypertension or diabetes or whatever conditions. And the biggest challenge by far we have is that so many employers say, I can't afford to add this. Where instead of thinking, I'm just trading costs, I'm already paying for things, why not invest? And the whole adage goes to pay me now or pay me later. And we're a pay me later society, especially when it comes to healthcare. and trying to convince them and show them through the data that, what can happen. And thankfully, we have these wonderful examples of success that help an employer become a smarter consumer, because they do own the keys in how this can be set up much more effectively.
Thank you. We're going to come back and talk a lot more about patient engagement, but what I hear you emphasizing is upstream investment can reduce your downstream costs. But that is a real mind shift in our current system. And there's lots of pressures that move us in the other direction. Pashmaja.
Yeah, I would say I was able to integrate a whole person approach into patient care using the lifestyle medicine high value framework. It's kind of a holistic lifestyle medicine primary care approach, is fundamentally different from the traditional reductionist allopathic medicine models. And the differences really include more around team-based care, group sessions, patient engagement, and shared decision-making. I would say the biggest contributor to my success with implementing these programs was around creating strong support system for patients through both clinical and community resources, ensuring that patient had access to multidisciplinary team, including physician, nurse practitioner, dietitian, and health coaches, really help build a comprehensive approach to care. And then additionally focusing on behavior change strategies rather than just giving information, empowered patients to take control of their health. And I would say the biggest challenge I faced was overcoming this initial resistance from administrative staff and healthcare providers. Many were skeptical of a non-pharmacological approach to chronic disease management. And it took some time to build trust and demonstrate the effectiveness of the intervention through demonstrating real-world results and data. Educating both patients and providers on the science behind these lifestyle interventions was really the key to overcoming this barrier.
Thank you. So you mentioned a team-based approach to care. And my next question really relates to patient engagement. So how does that work if the patient no longer is just focused on, a more linear relationship with the doctor or the primary care clinician, but they've got a whole team now. So how does a team engage, and what happens to the relationship when you move from a one-on-one to more of a team-based approach? And if you could reflect on, because you've practiced under a more traditional model and now this model, what's different about the relationship?
So when it comes to patient engagement, I would say the clinicians who are trained in lifestyle medicine significantly enhance patient engagement by really improving patient activation through a holistic, personalized approach. And it's usually, because of our unique mindset, rather than just addressing symptoms, we think about, where can we find balance and addressing the root causes of health issues. And so it's about assessing patients' capacity for effective self-management. And that involves assessing their knowledge, skills, and confidence in managing their own health. Motivational interviewing really plays a pivotal role in our assessment, helping our clinicians gauge patients' readiness for change. And then to support these patients, clinicians often find this personalized education really tailored to their specific needs with some practical tools and resources. Often, many of us actually include health and wellness coaches to guide patients through the process. And then we often use community health workers or referrals to community-based organizations. So all of these key players really help patient get into this, get engaged into the process of lifestyle changes that we're trying to help them with. And at the end of this, patient is really an active partner. They are involved into this shared decision-making, and they're aware of the treatment plan. And the plan is culturally sensitive, values-driven, and really aligns with their goals. So I would say, yes, with time, this relationship really changes with early on, we're trying to sort of build, establishing trust. But with time, we're not just managing their illness, but we're really looking at their overall wellness, which really strengthens patient commitment to the process. And the fact that we really engage them into empowering them with the knowledge and skills, it really helps them build their ability to manage their own health. And with the understanding patients, not just their clinical health and their health, but also knowing them personally with the longitudinal relationship-based care really helps us to know patients well. So I would say it really becomes less transactional and more transformational. Our patient is not only treated for specific health conditions, but is really sort of supported holistically in achieving lasting health and wellness.
Thank you. I have lots of observations, but Alan, you're still practicing. What's been your observation with your patients?
So we've done much of what Dr. Patel has done. I think the biggest shift for us is going from the reactive model to more proactive. We have what we call a 1500 list, which are sickest patients, higher utilizers, and we use a team of navigators who are from the community. They're not basically healthcare trained. We train them to meet the needs of our patients. They get a cell phone. They're a direct connection. The patients call the navigators bring urgent things to the physicians. And it allows us to, look at things like what matters to the patient, what's important to them, and bring in those lifestyle components from someone from a similar background that they might look at me and, when I tell them they can't eat certain things and why they need to exercise, but coming from someone with the same background or a similar background from the community, a similar socioeconomic class, it just works so much better. So again, it's about that reach out. It's about trying to go from sick care to well care and meeting the needs of the patients that we have individually.
Super. We've got a lot of questions here. The next one actually is for you, Mary. What I heard was moving from transaction to relationship-based care. Pashmaja, you mentioned initially you're trying to build trust. So Mary, I'd love for you to comment a bit on your observations of this notion of trust, how important it is, and why has trust become something that people are all talking about now and recognizing that we've got to address?
So it's a great question, incredibly powerful. And it's funny that the data person is answering this question, but we work with so many employers over the country, and you look at their data and, I think I wrote down that I had 47 different employers that have on-site or direct primary care models. And the ones that are successful really have developed a culture of not pushing the person to do what they're telling them to do, but gaining trust, spending the time so people can be open and honest about what they need. The things that I've talked about already. What is remarkable to me is how this is going to pay off in the future. And I will tell you that there's this huge crisis now in the employer world on the cost of GLP-1s. In your commercial world, everybody wants it. Every commercial, you go down the street, you see someone that all of a sudden looks different, and you perceive them to be healthier. Well, these are $1,200 to $1,400 a month for these drugs. So when there's not trust, what's happening is people are going to the health plan, the employer, and complaining that they want access to this stuff. With Carmel Clay Schools, they are the first of, I guess there's about 5 right now that have put this into place, where they're developing a holistic approach to support people to improve their health. And other facilities that don't have trust are still getting all the complaints. And in this area, Carmel Clay Schools actually have received thank yous from their people, their plan members, to say, wow, you really do care. This is just another way you're showing me that you really care about me in the long run. And it's remarkable, because if you think about all the different ways GLP-1s could be approved for, hyperlipidemia. We laugh that a BMI over 27 hyperlipidemia is pretty much 67% of the population in a commercial health plan. If you multiply that by $1,200 a month, pretty much every client I work with will be bankrupt. Their budget will be sunk, or it's going to come out of their pay, or the premiums are going to go up. So that they have built the infrastructure so that people really do understand and believe that this wellness center is set up to support them has allowed them now to lay the groundwork to really support people in a much more progressive way and use a GLP-1 as one of the tools in the toolbox, but also create the right culture. And even at Alira Group, we're working on the culture, leveraging the blue zones. We've just started a program in that because we can put in all these wonderful programs, but if they go home or go to the office and there's M&Ms and Diet Cokes and no one's allowed to stand up during the day, none of this is going to work. So creating a culture that also helps people make the right decision. I noticed in one of the questions here was about the incentives. These programs don't have incentives. The incentives is it's answering for the person's needs, versus there's a lot of companies that throw dollars at this. And guess what? As we all know from many years of research, you just have to keep adding more and more dollars, and it's really not creating personal change. So that's really where this is different.
Thank you. And let me make sure I understand. So these new drugs can be made available, but it's in the context of many other solutions. And I think what you're saying is that because of the relationship that's been developed, people are willing to explore these other options before they, maybe someone needs the drug, but it's not what people are asking for right out of the gate. And it is a trusted relationship because what they eventually pursue is based on, a much more elaborate conversation about what makes sense clinically.
Exactly.
Super. Anybody want to comment on that? I mean, I think it is a remarkable example, and we know that employers are dealing with this very question all across the country.
I'd love to respond quickly. So
yeah, sure.
It's unfortunate that, many of the plans are waiting for people to get sicker to cover for them. So it's a shame, like have a heart attack or a stroke and maybe we'll cover it. So I'm a big Osler fan in the art of medicine, and realistically, everything you do as a primary care physician is about, relations, communications, and trust. And if you don't have that with your patient, like you do not have a good, primary care relationship with them.
Thank you. I do want to ask about teams, but first let me go and talk about payment models because that's come up. You all have slightly different payment models, and I'm wondering if you might comment, and we're going to ask Mary just to quickly lead off here about how the payment model you think either incents or maybe in some cases, undermines what you're trying to achieve.
Sorry, couldn't find my unmute button. So, I think probably everyone on this call understands why the current payment model has created exactly what we have, is that if we've all agreed that the primary care relationship is an art, it's, there's scientists, but there's an art to this, to really having a relationship. And what do they get paid for? They get reimbursed for about a 7-minute encounter. That doesn't include documentation. So that has really derailed. And as everybody here knows, with the triple aim or quadruple or quintuple aim, I guess it's now, we've basically watered that down to being almost meaningless. And in the models that we're doing with commercial health plans, it's unfortunately going around what the commercial plans have done, because the commercial plans are not valuing the relationship. They're not providing enough reimbursement. So what we're doing is adding an additional resource so that these programs can allow for a longer discussion, a deeper relationship, all the ancillary services, like a dietitian. I laugh when we first got involved in this probably 15 years ago. When I was on the provider side running a medical practice, the no-show rate for PT, for even counselors or dietitian is outrageous, because who's going to pay the out-of-pocket to go to that on a regular basis and leave work or figure out childcare? But if it's provided as just a resource to support you, it's amazing the engagement rate you get and the impact. So, unfortunately, I feel like our society has now moved to paying for all these on-site clinics. And why I say unfortunately is because there are great providers out there within the healthcare system that can provide these resources. But what's happened is we've commercialized this. So now there's another administrative entity that's making a ton of money off of this instead of investing in the primary care providers, allowing this as an extension of the wellness provisions in a health plan, and just pay so that these resources are available. Sorry, that was a bit of my soapbox, but that hits under where I am every day.
So just to make sure that everyone is here on the same page, what you see with employers is they're continuing their insurance arrangements, but they have these on-site near-site clinics that are more comprehensive primary care. And those are probably wealthier employers that can afford to do things like that, and larger employers that have the enough employees in a given geographic market to do on-site and near-site. I understand others are looking for direct primary care, again, outside of insurance. Others want to comment on payment arrangements and how they support or don't.
Can I make one quick comment? I don't want there to be the perception that it's always better quality, because it's not always. They may market it as such, but when they say lifestyle medicine, it may not really be a comprehensive approach. So I don't want to think that just because you have an on-site clinic, that means that you've added higher quality. Sometimes it's because they may be in a community where there's just no primary care at all.
Got it. Thank you.
So we're doing similar. Unfortunately, we're in a dichotomy where half our patients are in value-based capitated arrangements and half are fee-for-service. We refuse to allow our providers to practice two standards of care. So it's lifestyle medicine for all. Like, everyone gets access to nutrition and exercise and mindfulness, what's needed for the comprehensive care of the patient. You just can't have two standards of care out there. You just got to do it.
Well, I appreciate that approach. I'm sure your patients do too. Pajma.
Yeah, I would say I have a little different take on this, which I would say, yes, we acknowledge the limitations of the current fee-for-service models, but I have seen, and we have demonstrated, our clinicians have consistently demonstrated that it's possible to deliver whole person care even within these constraints. And there are lifestyle medicine care models that we have successfully implemented within fee-for-service models. For example, lifestyle medicine shared medical appointments. This model emphasizes multidisciplinary team as part of the core team and can be integrated in medical appointments, and where clinician works as a specialist or a team leader and works with patients to really address these lifestyle factors. And ICR, the intensive cardiac rehab, the example that I already gave, which is, again, a holistic whole person approach with a robust payment model. And then there is collaborative care model which can be expanded to deliver physical health as well as mental health. And we've seen some successful examples of that as well. So not to say that we clearly need better payment models, but I would say we don't have to wait for a perfect model to arrive. We could clearly integrate some of these models today.
Super. So you're pointing out a couple of facets, either mental health through collaborative care, or the joint visits is for chronic care management. So there are pieces where you can do it. Would you say that you can speak to all facets, or is it more kind of targeted, and a capitated model or a hybrid model might give you more flexibility? Just curious.
Yeah, I would say hybrid would be perfect. I think it would really give that prospective payment to clinicians to develop interdisciplinary teams and resources and design innovative care models. So yeah, and then in addition, bill for those fee-for-service visits as well. So I would highly support that we probably go in that direction of creating hybrid model for primary care providers.
Thank you. Well, these things don't happen just organically. They need, I think, some leadership and receptive governance. I'm wondering if you all could reflect on, what kind of individual or governance structure, what has made this possible? Because there's many examples of great ideas that never take hold because they hit barriers at the board level, or even lower down on the food chain. So I'm wondering if you all can reflect on what leadership or governance has made it possible for your incredible innovations to proceed. Alan, you want to key us off?
Sure. I'd say it's everything for me. I was able to, bring in the quote experts from out of town. I've been preaching this for 25 years or 38 years that I've been in Jamaica my whole career. And, they listened to me, they saw the great things we were doing, but bringing in the great minds and showing what we were able to accomplish in short periods of time. And it was certainly my CFO was, the last one to believe in what we were doing. So getting the buy-in of the C-suite was huge in my institution. But we were able to show them the data. People who had the high value visits had met the quintuple A more, the quadruple A more. And we were able to show mostly to him, which was the biggest, with value-based purchasing, the excess medical revenue from the care literally went from about 50 million when we started over 4 years to almost 120 million. And he couldn't argue that it wasn't from delivering whole person, patient-centered advanced primary care.
Super. Would Mary or Pashmasha want to comment? Then we'll open it up for questions.
Well, I would say in my case, I attribute program success to two key factors. First, because the health system, was self-insured. So it had been, consistently overspending on their annual employee benefit plan. So my proposed solution was really designed to directly address that pain point by reducing healthcare cost through this program. And secondly, health system had redefined its vision, mission, and values with a strong focus on improving community health, with the goal of making Midland, Texas, the healthiest community in Texas. And so lifestyle medicine became a core component of that broader strategy to achieve that vision. So I think this alignment with the organization's larger objectives really created a strong foundation of what I was able to create locally.
If I could add, then I think
sure.
what I see on the commercial side is that HR people have a hard time trying to do anything different. If you try something new and you fail, you're in trouble. But if you buy the same old sausage everybody else is buying, it's okay. So we've done the same thing over time. Yeah, sausage is probably a bad term to use on a medicine conversation. Well, that's really how bad it is, though, really. So instead, with the data, we've been able to make this information as objective as an employer would do for any other business decision. And if they can look at the risk of their people, as Alan showed, how much do the highest cost claimants spend? Those people with the highest risk, why are my people that do not have a controlled A1C costing, it could be up to $18,000 more per year per person. That makes it really easy to understand why you have to take a different approach, and then allows you to show that if that approach is working or not and when to shift. So I think it really changed the conversation for employers, and hopefully we'll start to make better financial decisions along the way.
Well, we have so many incredible questions that have come in. We could be here for the next 2 hours. I kid you not. I mean, people are very engaged and have quite a number of substantive questions. Why don't we start with risk adjustment? Both Alan and Mary talked about risk adjustment. And first, Dr. Roth, can you explain exactly how you're doing the risk adjustment and what variables you're considering, and are you also considering social risk?
So health-related social needs are part of our risk score. It comes out in a whole person risk score. Every time my provider sees a patient, the score flashes up on the screen. They know how sick our patients are. And it's based on over 500 modalities relating to, diseases, chronic diseases that they have, the cost of care, ER and hospital utilization, how well they're using the healthcare system. They're going to their primary care provider and not going to 15 specialists. They're taking their meds, they're not taking their meds, they're closing their care gaps, they're not closing their care gaps, they're showing for appointments or not. So there's over 500 modalities in the risk score that we're utilizing. And we're proactively, like, again, we're not just waiting for those high-risk people to come in. Those that haven't had a visit in 1 year are prioritized. Then it's those that haven't had a visit in 6 months, and then those that have the highest risk. So we prioritize and work hard through our navigators to bring people in to get the care that they need. So I think
Thank you.
risk
That's a
adjustment's
lot of
everything.
variables. How much is the clinician actually responsible for inputting those variables, and how much are those, sort of derived from the electronic health record?
Zero. So all the data is coming through our EHR. We're fortunate enough to be able to marry the EHR data with financial data from the insurance companies. So it's getting a mix of both. So, if my patient ends up in a competitor's hospital ER, 30 miles away tomorrow, we're going to get that data. So it gives us comprehensive data. So our docs just have to look at the score.
Thank you. This is also related to you, and this was a question for everyone. If any of your results have been written up in a peer-reviewed article, and I know you're
We're working on it.
publication, right?
We're working on it.
Coming soon.
All mine are. All mine are published, and I think there's a link there, so we'll share.
Oh, perfect. Thank you so much. And I think we also have a publication on the Clay County schools. That will be sent out post-webinar. It's a great question, and we, of course, applaud as these innovators are doing all this hard work, also taking time to publish the results. That's really important. Mary, did you want to say anything about risk stratification?
Yeah, we do leverage Johns Hopkins ACG system, which is really critical to our process. We integrate data from, if it's a carved out healthcare plan, like an on-site clinic that may not go through the carrier. We also add the carrier data, any vendor strategy, anything else that's out there, PBM files, everything, and then leverage the Johns Hopkins system. And the Johns Hopkins system allows us to identify things such as pivotal future cost drivers, that 1 to 3%, that'll be more than 30%. I think Dr. Roth, same thing you're talking about. And with Dr. Patel talking about those that have chronic conditions and are not controlled. We're not looking for, I'm not picking on Dr. Roth when I say this, but everybody thinks they still need to close prescription gaps. Well, the PBM does that by just mailing the drugs. So we really aren't looking at that. We're looking at control of A1C, control of blood pressures. And again, what was fascinating about Carmel Clay Schools is to see the decline in the number of individuals with these chronic conditions, and as well as the improvement in their prospective risk score. It's like the fountain of youth. And what was really interesting there is that they've solved for so many things, but they could not get around the blood pressure issue. And then it really came up that it was more stress. So they added mental health. And actually, we just delivered their latest report last week, and their numbers of people with hypertension have really declined. So it's just exciting to see that it can actually move, and these risk scores are objective and really showing change.
Fabulous. A number of you brought up, I think Dr. Patel brought up reduction in pharmacy costs, but a number of you have talked about, not your therapies don't necessarily have to be drug therapies, and reducing of drug costs. So one question was, do you have clinical pharmacists involved in this work? And if so, how do they function? Who would like to go first with that question?
So we have clinical pharmacists in the background, not with us, that are helping us do med reconciliation and ensuring our med lists are up to date, but we don't have them, unfortunately, at the point of care right now.
So we have clinical pharmacists as a part of our lifestyle medicine members, and they are actively engaged in care team and as a part of our multidisciplinary team. And their role is actually helping patients often help with this de-escalation with all pharmaceuticals. So there's clearly a role for pharmacists and a clinical pharmacist to help us move the needle in the right direction as patients gradually come off of their therapeutic medication. So we've been clearly engaging clinical pharmacists as part of our care team.
Super. We have a variety of kinds of settings represented on this call, but others are jumping in and saying, how could a model like this work if you're an independent physician practice. So that's one question. Hold for a moment. How might these models work in an FQHC is the other question. So who would like to respond?
So I can say that for private practice physicians, I would consider the health plans of local employers part of your strategy. Get to know them, understand what their needs are, and determine how you can help support those efforts. There's not been a lot of communication between employers, and which are the payers of the health plan, and the providers. The carriers typically in the middle setting up the rules. So how about we step outside of that and have that conversation? And in that, we have a lot of where we've created top tier networks for primary care for providers, and we pay an extra admin fee to help support these extra services. And then we even provide, we call them our report cards, so that on a quarterly basis, they'll know how they're doing. Are their providers really improving in the areas that this employer needs? So it really is a wonderful structure, and I think empowers the providers to make more decisions.
And I would add that independent practitioners, primary care clinicians could clearly integrate these models into their care plans. Again, it depends on the payment models that they currently have. So as I indicated, there are clearly models, even within fee-for-service payment structures, that could be easily adopted. And in value-based care, obviously, as Dr. Roth has demonstrated, there is clearly a room for these models to thrive. As far as FQHCs and CHCs go, we have a robust data around our clinicians and members who actually practice in these settings and have demonstrated whole person care and integration of lifestyle medicine across the board.
So we're essentially an FQHC without, the reimbursement enhancement, and it's just the right thing to do. I mean, you need to care for patients, and a holistic advanced primary care approach utilizing lifestyle medicine is the right thing to do.
Well, and Alan, one of the comments is that your PMPM is very low, and there was a question about that, and I think it is. I mean, you're basically serving a Medicaid population.
It's 90% Medicaid, our PMPM. Okay, we are almost at time. We've got 2 minutes, so I'm just going to see if anybody is using AI in any of the analytic work or any of the other care management work to help support your models. Is anyone? I mean, that obviously we're all learning about how to integrate AI. So that may be a future webinar on how we can leverage.
We're just starting to pilot that to be able to see if we can identify future costs, but that's more than to show that we've really bent the curve for the intervention. Like, just another way to analyze it, because already with the risk indexing, I think we're already getting what we need.
I'm sure in the next year, it will be the entire webinar of what we're talking about now, utilizing AI and data analytics.
We're all going to get up to speed. Yeah.
In patient behavior change, I think there's a tremendous role of AI and all the systems digitally that we can add. So there's clearly a lot of scope and room for us all to see how that unfolds.
Thank you. Well, thank you so much for a wonderful set of presentations, really incredibly inspiring. And I think collectively we want to change policy so that we can spread and scale the sort of work that you all are doing. As you know, PCC's focus is largely on changing how we pay and how much we pay primary care to be able to have these models be available across the country. But there's clearly many other strategies that are going to be important related to the workforce and team-based care and many other things that need to come online at the same time. Please look for the follow-up email. Send us your ideas about other programs that we should pursue. Next month's webinar is going to be focused on payment models more broadly, and you'll be getting information about that shortly. Please join me in thanking these wonderful panelists and enjoy the rest of your day.
Thanks for having us.
Thank you.